Welcome to the concept of elimination. Today we'll be focusing on bowel. Throughout this PowerPoint there will be videos and questions that you will need to watch and or answer. You guys have already been introduced to the concept of elimination. It is just the simple definition is excretion of waste products, and that can be either through the renal system or, like what we're focusing on today, is the bowel. So some related terms that we should know. Defecation, you should know at this point in time, is the act of passing a bowel movement. Continence, whether they have control of it, or incontinence, whether they lack the control of it. Now, another one that's interesting that you probably haven't talked too much about is obstruction, and we'll focus on that a little bit more throughout this PowerPoint, but just basically an obstruction is what you think it is. You have your intestine, and then you have some form of obstruction that is stopping anything from passing through. So it just, stuff can't literally go through. Now what happens a lot of times when you have obstruction is you then have lack of blood flow then to the area, and it starts to lose, the tissue starts dying, and you become necrotic in that area, which means lack of blood flow, and then the tissue death that follows. So those are two terms that may be a little bit more new to you. With obstructions, there's a couple ways of categorizing them, I guess is a good way of putting it. You have a mechanical obstruction, which is a physical obstruction, something that blocks the passage of the bowel. Okay, so that's literally going to be, here's your bowel again. That's going to be like a tumor that's pushing in, or some sort of adhesion or scar tissue that has built up in this area and is stopping anything from going through. That is a mechanical. It is stopping the passage, okay? And then you have non-mechanical. So as our bowel works, as you learned from like your anatomy class, right? There's motility, and it kind of slowly contracts, and that's called peristalsis, what moves the poop and the waste products through there. Well, what happens is you have great motility, everything's working, everything's moving through, and then for some reason the bowel just starts to lose that motility, and it's just not working in that spot, and that can be like a nerve injury. Otherwise, something very common is an ileus. So you have stuff moving, and then it just kind of stops moving, and then stuff starts to kind of build up and impact in there. So that can cause a lot of problems for our patients. Some risk factors people have with elimination related to the bowel is going to be your populations are going to be your pregnant women, your elderly, and the young. Diseases of the GI system, irritable bowel syndrome, it causes a lot of issues with elimination in the bowel. Cancer, again, you got those colorectal cancers that cause a lot of problems. And then something people don't always think about is side effects of medications. A lot of side effects of medications slow down your motility, or cause constipation, then cause impaction, and then cause lots of problems. Any malformations of the GI tract can cause problems with elimination. A hernia, which is an outpouching of the intestine, or intussusception, which is kind of interesting. It's like literally when the bowel telescopes itself in. You don't see it too much, but so like here's your bowel, and then all of a sudden it like folds in on itself. So you've got this like kind of telescoping piece. So here's your bowel, and then all of a sudden it just kind of folds in on itself so that it's going in there, and then that can cause a lot of constriction problems. And then anytime you have any constriction or anything like that, then we've got that risk of necrotic tissue, right? Because we've stopped the blood flow. And then if it gets even bad enough, you get peritonitis, which peritonitis is pretty awful and painful and pretty deadly. So we have to pay attention to our patients when they start having big bowels, big issues with their bowels. If they perf, which means that intestine ruptures and they get peritonitis, that GI content gets into the peritoneal cavity, we are in big, big trouble. So we talked about our at-risk populations and why are these people at risk? So we've got our pregnant, let's start with our pregnant women. We've got a uterus that has increased significantly. And, so you've got that huge, big uterus with a baby in it, lots of pressure, right? And lots of fluid in there, and it's all putting weight on that bowel and pushing that bowel out of its normal area. So it causes pressure and then it just slows it down. Not to mention the babies take lots, but they take lots of nutrients from us, so we don't have as many nutrients to waste and absorb in there. Let's talk about the elderly here. So our elderly, as we age, just like with everything, you see all these nice little peristalsis lines here. They start to slow and they start to kind of smooth out, and we don't get as much of that nice, quick motility as we have as a younger adult. So, as a younger adult, we're moving, and as we age, we're just maybe not moving as much. Another thing that elderly have is what do elderly patients take? They take a ton of meds. So many meds that it slows, so it basically slows down their GI tract even more. They are the red light of GI motility just because one, they're not moving, and two, they're taking so many meds, and three, the age. Just generalized with age, we slow down, so they're just not moving as much. The young are kind of an interesting one when they're potty training and learning how to poop in the toilet. They don't want to stop to poop, to stop playing to poop, so they just don't poop. And so some kids get really big problems because they haven't pooped because they didn't want to stop to poop, or because it's a control issue. So we really need to talk with kids about making sure that it's important that we take time to go to the bathroom. Even if we need to teach parents to take their iPads into the bathroom with them, we want to make sure that those kids are taking their time to sit down and go to the bathroom. So we mentioned hernia before, or hernias before, but what a hernia is literally an area of muscle wall that has broken apart and the intestine is protruding through it, making that outpouching look. What do they do for it? Well, if it's non-painful, you're really not going to do much for it. If it's not causing any complications. You might tell patients that they shouldn't lift anything heavy or pull or push, anything that can increase that abdominal pressure, because, they might push it out further. Things to consider is if it can no longer be reduced, which means it can't be pushed back in, means that it's tightened and constricted, and that it's going to cause a problem like lack of blood flow, constipation, bowel obstruction, those kinds of things. So until it becomes that, is when we have to worry about it. When is it bad? Well, it's bad when somebody starts having all of a sudden pain, swelling, discoloration, fever, chills, anything that's going to let you know that it's infected or that the intestinal lining has ruptured and now you have a peritonitis. That all can happen when a hernia becomes incarcerated or strangulated, and it means that it's constricted around that tissue, which then is causing that lack of blood flow and the necrotic tissue and cell death. So as long as it is reducible and can be kind of pushed back in, it'll be okay. Other things they can do for hernias is some people wear a truss, which is like a belt or a tight underwear or whatever that helps hold those in. Assessment for anyone who's having any abdominal discomfort is going to be relatively the same as all assessments. You're going to want to get that detailed history, including the medications, and any other medical histories that they might have if they've had other problems. Abdominal surgeries we always want to know about because of the adhesions and the scar tissue that can build up. You might want to know any family history of anything like cancers. So you're going to really want to pay attention to your medical history. As far as examination, we're going to do a basic head-to-toe examination. You might focus a little bit more on that abdominal area, right? So we're going to listen with our stethoscope in all 4 quadrants, and we want to hear, active bowel sounds. We're going to look at that belly and see if it's really big and distended, if they've got a lot of bloating going on or discomfort. We want to pay attention to that. We're going to pay attention if they've got a lot of bloating, if they're having problems with breathing, because those intestines, they can get up there and be pushing on those lungs and causing problems. So we want to make sure that we don't have intestines getting backed up underneath the lungs and pushing up on them. We want to pay attention to pain assessment. We want to pay attention to their neuro. How are they acting? Are they anxious? Are they in pain? And just a basic head-to-toe assessment. As far as diagnostic tests for these patients, we're going to make sure that we might do like a KUB, which is an abdominal x-ray. We might do a CT scan to look for gas bubbles and stuff like that in there. You're going to check labs, CBC to see if there's an elevated white count. You might do a stool check where you are going to look for blood in their stool. And then you might also do, if all these diagnostic tests are negative or you're still trying to figure out what's going on, we might do a colonoscopy.
The procedure.
Yeah, I mean, the big question is when you should get it done. And people don't realize you get it done when you're healthy. Men don't want to hear that at all. They want to have a symptom, they want to go to a doctor when they're not feeling well. But this disease we can prevent, and that's the key, but you have to do it when you're well. So by and large, anybody the age 50 or over should really be talking to their doctor about screening for colorectal cancer. Now, of course, there are other reasons to do it earlier. If there's a family history, like in Jay's case, his family now are going to have it at a younger age, starting starting at 40 or younger. Women can get this disease just as frequently as men. Often women don't realize that. They think this is a man's disease. I don't know why they associate colons with men, but generally this is not thought of a women's disease.
Because it's almost the same number,
exactly.
50-50.
So women need their mammographies, they need their pap smears, they need to see a gynecologist, but they also need to be screened for colorectal cancer.
And I always say no family history is no guarantee, because 75% of all colon cancers are first time in a family, so they have no family history.
Here's another big deal, though. Healthcare costs are out of control. Does insurance, as a rule, pay for this?
By and large, if your doctor recommends it, insurance will pay for it. There are 33 states that actually mandate it. We applaud those states and actually hope more follow suit, because it's really important to focus on prevention. This is a disease that can be so devastating, as we know from personal experience, but it can be prevented, and that is the most important message.
And the key, Harry, is getting it before it can develop. So one of the reasons you get a colonoscopy is because you can actually remove a precancerous or even cancerous polyp before it develops into a tumor and permeates the colon wall, goes into the lymph nodes, and metastasizes to other organs.
Knows what she's talking about.
No, but it's really important, because this is one of those cancers you can actually stop it in its tracks.
Nip it in the bud.
Or butt. Yes, go ahead. So Mark's got the scope. He's going to show us how
check this
works.
out. This is amazing technology.
It really is an amazing feat of technology. What we have is a device that can move in 4 directions, up, down, left, and right. And I'm using my thumb to control these wheels. And this little wire you see isn't normally here, but I have it here for demonstration. So if we do see a polyp, we can extend this little...
we're pretending this is a polyp.
Right. We extend the snare out. David, you want to open the wire? We put this loop of wire around the polyp and close. And then normally we'd put a little electric current through, which would cause it to cauterize and cut the polyp off. But of course, we're not going to do that now.
Yeah, because Harry needs that finger, Mark. Please don't.
Okay.
And we would remove the polyp, so it's diagnostic and therapeutic. We can remove the polyp and prevent it from ever having the chance of turning cancerous. And the image, Harry, is incredible.
Yeah, take a look at this.
For example, if we look at your arm, we could see every hair follicle really in absolute detail. We can see it coming out of the skin.
Look at there it is.
And
wow.
it magnifies.
That's kind of grody, actually.
Yeah, we could even, if you look at the sheet, for example, you can see every weave in the sheet.
And
so the amazing thing is we have this high definition clarity of these scopes and the technology to detect even early and flat polyps and remove them.
So we're going to take the colon cam and look inside here in just a little while.
That's right. They're going to get you ready for the procedure, give you some anesthesia, insert the endoscope. I'm going to actually, I love you, but not that much. So I'm going to sort of make a quick exit for that part of the procedure, and then I'm going to join you sort of midway.
Right.
And there's no one who's enjoying this entire experience.
Ben, how you feeling?
I'm doing great now.
Okay.
But to be able to, you know, sort of come to toward the end of the procedure and be able to talk to Mark, to talk to Dr. Pachekin and say, have him say, this all looks great.
Yeah.
You
the
know,
good news is Harry's colon is clean as a whistle, first of all. So you inserted the endoscope all the way to the end of the colon, and the real test or the real procedure is when you check through the camera on the way out of the colon, right, Mark?
Right. What we're doing now is we're looking at all the little folds here. You can see it on the monitor that as we pull back the scope and we put a little bit of air, and actually we're using carbon dioxide because it gets absorbed very quickly, we could see the intricacies of the colon, see this normal blood vessel pattern. And actually, as I withdraw it this side, you could see there's a little bit of a bluish blush just in the middle. That's actually Harry's liver.
Oh, really?
Yeah, we're at what's called the hepatic flexure, which is
hello, liver.
Yeah, not many people get to say hello to the liver. And as I withdraw now, we're coming across the transverse colon. The transverse colon usually has a little bit more of a triangular appearance. You can almost see that as I
look at that.
come back. And actually, what's interesting, there's no bone or cartilage in there. That's all muscle just contracting. And that's what keeps the fluid from coming too quickly out of the body. And the colon's job is really just to remove fluid. It's basically the dryer of the body. It's the sewage system.
And this is just sort of cleansing it so you get a better look. And you also have to look for flat polyps as well. Sometimes polyps protrude out like little warts, I guess, right? But sometimes they're flat.
Katie, what we like to say is they don't always present themselves well.
That's true.
Well, they could be hidden behind folds, or they could be very difficult to see.
I'm a little worried. I told your wife, Andrea, I'd be, you know, if you said anything inappropriate, I'd make sure to...
Yeah, she was afraid I was going to tell too much of the truth.
I want to show you an interesting technology. It's called narrowband imaging, or NBI. And what it is basically a blue light that enhances the vascular pattern.
Wow.
And you see if there was, you could almost see each of those little dots are actually the glands in the colon. And you could see the blood vessels. If there was a very flat polyp or difficult to see polyp, we have a better way
see it then,
of seeing it. Yeah. Exactly. All right, David.
Now that thing we just passed, that's not a polyp, Mark?
That's just a little residue. The colon will always have a little bit of mucus or residue in it, but you can see how clean the prep works in terms of making sure that we can see all the lining.
About a year ago, there was some controversy that some doctors were missing polyps or flat polyps, and it really came down to the fact that they were doing the procedure too quickly. Is that right, Mark?
That's right. You know, there are certain quality indicators. One of them is the withdrawal time, how long you go from the very beginning of the colon to the end. And the minimum amount of time should be 6 minutes. We strive here, we look at the clocks to be at least 8 minutes. And the longer you take looking around these folds, the better you're able to see these little small polyps or flat lesions. You could see how, if you're not careful looking around these different folds, that things could hide. See how you push forward and you look around these folds here, and then you pull back. And
when you're getting a colonoscopy, you should ask your doctor, how experienced are you and how long do you take to do the procedure, right, Mark?
Exactly.
To make sure you get somebody who really knows what he or she is doing.
The other quality indicators, by the way, is how many times you actually find adenomas. And the baseline standard is 50,
or cancerous polyps?
which are the precancerous polyps, the polyps that you really want to find and remove. And the baseline is about 15% to 25%, 15% for women and 25% for men. So they're out there. We just have to make sure we take our time and do a quality exam. Good prep, slow withdrawal, And of course, making sure the patient's safety and comfort is always present.
And a colonoscopy should be done every 10 years. You can do a flexible sigmoidoscopy, but that only really views half the colon, right? It's
That's
sort of like
exactly
getting a
right.
mammogram on one breast.
Not many people do flexible sigmoidoscopies anymore. If you're already in the colon, you may as well look at the whole colon. There are certain groups, like African Americans, that tend to have more polyps on the right side of the colon. So, you know, it's the best way to look. It's really very straightforward.
And how many feet is this?
The colon's
Remember from
anywhere between-
biology class? From high school, what is it? Is it 12 or 18?
It's, no, 4 to 6 feet is the colon, but
Right.
the small intestine can be 20 feet.
Okay.
And you have apparently a very long colon.
Yeah, yes.
And by the way, I just want to point out I'm wearing my splash shield because I was told I was going to be in the splash zone, and I could have gone all day without knowing that, Mark.
Sorry about
but
that,
thank
Katie.
you. Anyway, Erica, we'll come back.
So now we've seen a colonoscopy. Really, we don't want to get to that point. So we really want to do some management prior to the need of colonoscopies. Although over a certain age, you're going to get a colonoscopy no matter what, hopefully as a prevention. But we can do things prior to that to preventing elimination problems. So primary prevention, really basic, really simple. Nutrition, fiber and water, things that we don't get a lot of. Think of your diet currently. How much water have you had today? How much fiber intake have you had today? Because I know me, I drink my Pepsi, and that does not count as water. Definitely not a nutritious thing to bring in. The other thing is physical activity. The chair is our killer. That sedentary lifestyle is awful for pretty much every part of our body function, but definitely including our GI motility. So what I want you to do, I'm going to challenge you to do some exercise today, and let me know what exercise you did today. I don't care if it's 10 jumping jacks or walked your kid to school or whatever, but what kind of exercise did you do today that got you out of the chair? Secondary prevention for elimination is going to be a hematest, which is literally you take a little bit of poop, you usually smear it on a card or send it down to the lab, and then we check that stool for blood. And if there's blood in the stool, that's bad. Blood should be in the vessels, not in your colon. So we'll have to try and figure out why there's blood in there. Another thing that you might hear about with blood in the GI tract is coffee ground emesis. Anytime anybody compares what they're bringing out of their body as coffee ground, that's bad. It's usually coagulated blood from some type of bleed, whether it be upper or lower. And then our colonoscopy is our other secondary prevention. Again, we might just get it done if you're a certain age. That age keeps changing depending on history, family histories, or any of that kind of stuff. So you just make sure you want to pay attention to what's going on and what your doctor is recommending. Okay, so our collaborative interventions are going to be our pharmacological agents. We're going to talk about antispasmodics, usually used a little bit more with renal issues than necessarily the bowel issues. You've seen Vesicare and Ditropan. You see the commercial of the little bladder like tugging the lady's arm, and that's one of these, either Vesicare or Ditropan, I can't remember, but it's for that spasm that the bladder can have. But for irritable bowel syndrome, you'll see Bentyl, Bentyl, and belladonna suppositories are used sometimes, because if you can imagine, people with irritable bowel, they have that spasming of the gastric and the GI motility and the colon, causing all that pain and discomfort. Another pharmacological agent is antiemetics. So this is for people who have nausea, vomiting. Common ones are going to be Zofran, Phenergan, Compazine, and Reglan. Ativan is another one, but that's more commonly used with people that have really uncontrolled nausea and a lot of problems. Typically, I've always seen it with my cancer patients. They use Ativan a lot for nausea, and it works wonderfully. Other things we would use for pharmacological agents are pain medications, because if you can imagine, if you've got problems with your gut, they're having problems, they're having pain, and we need to give them some pain medications. Narcotics are going to be an issue, though, because what's a side effect of narcotics? Slows down the GI motility. Okay, so then it causes more constipation. some nursing interventions for that, get them up and moving. That mobility, it's so simple, but people think it is so complicated. We always have to have our hands on doing stuff. Well, sometimes simply just getting up and walking is our best medicine. Laxatives are another thing that we can help give people to keep them going. Psyllium, milk of mab, and fiber are all things to help keep that GI motility going. Other interventions that can happen are surgical interventions. So when we're talking about a bowel resection, it's pretty much what the words say it is. So here's your stretch of bowel. You have something in here causing problems, whether it be an ulcer from disease process, or it be a tumor, or it's something that's causing problem, causing pain, and causing blockage. Okay, so we've got that tumor there. Literally what they're going to do is, let's see if I can get the right color that I want here. They're literally going to cut here and here, and then they'll end up reattaching. Let's see if I don't want to do that. They'll end up reattaching the intestine together, okay? Another thing that they can do if they can't reattach it together to keep the flow going is they'll cut into it and make what's called an ostomy. So that's where they couldn't reattach the pieces, but they'll literally take a loop of that bowel and pull it outside the abdomen cavity and put it so that bowel's coming out. And we'll talk a little bit more about ostomies in the next slides coming. Nursing care across the lifespan. We have to think about things, how this is going to affect people throughout the lifespan, from when they're a little kid and you're having bowel issues to older adults that are having bowel issues. We don't have real great control as little kids, and we don't have real great control as we get older. So just thinking about how different age groups, how you might teach people differently as they're young or they're old, or how you might intervene differently. If somebody is in a wheelchair, as an elderly person, you're not going to be able to do the mobility interventions as much. So you're taking care of an ostomy patient or a person that's getting an ostomy. What kind of things do you have to worry about when you're taking care of this patient? Well, the first thing you have to worry about is their diet, because you do not want them eating steak and eggs prior to having this surgery, right? We want that whole system completely cleared out. So for 7 to 10 days, you're going to have a low residue diet. You just don't want a lot in there. And then within the last 24 to 72 hours, you're going to switch them over to clears, which means those clear liquids, which are oh so delicious, that Jello and tea, maybe some apple juice, stuff that you can see through, because you really want that system pretty well cleaned out. You might need to give them some vitamins and minerals to help supplement the restricted diets, just depending on their nutritional status prior to going in. It also depends on why they're getting an ostomy. If it's a bowel obstruction that they're getting an ostomy, then you're not really going to be giving them anything to take in that way anyways. Antibiotics, they usually do prophylactically for the infection site, but the other thing is that you're cutting into the gut, and there is a risk of contents, of those GI contents getting into that peritoneal cavity and causing a lot of problems. Other things that they can give are laxative or enemas. Again, everyone's favorite, but we may be giving those because really you want this system really well cleaned out. Another thing that they might be able to do is like the Go Lightly or the Movie Prep. Those are all given for colonoscopies, and again, those get you squeaky clean inside. They clean you all the way out. Nasogastric tubes are commonly seen because you want to rest the gut. So it's not uncommon to see a nasogastric tube. Again, really depends on why they're getting ostomy in the first place. If again it's for bowel obstruction, they really want that gut rested, they're going to give them a nasogastric tube at that time. Some post-op cares are going to be pretty much the same as your typical post-op cares, right? You've got those basic ones, the vital signs, assessment, pain, hydration, nutrition, infection risk. All of those things are going to be your basic post-op cares, right? But something that's different about ostomy patients is that psychosocial piece, because I don't know about you, but that would be a huge change in my lifestyle to have an ostomy placed on me. Not to mention the cares that are going to go with it. I mean, we're all pretty used to pooping in the toilet at this point in time. Putting that on your abdomen, a lot of change. And it's gross and people don't like it. So really assessing how they're going to adapt to it, how they feel about it, assessing the family dynamics for it and how the family's going to help them deal with it. Are they able to look at it yet? Or is that not what they're going to be able to do? Are they going to think that their wife is going to take care of it? Because we run into that a lot where it's like, well, don't teach me, my wife's going to have to do it. Well, it's on your body. You should probably know how to deal with it. Another thing that's different with these guys, or specific to these guys, is the stoma care itself, right? So we've got the wafer that we cut to go around it that has the adhesive that we'll put on it. We've got the bag that's going to be attached to it that's going to collect the waste product. Okay, those are pretty basic in just keeping it clean. But other things is like documentation on a stoma care. We want to know what it looks like. A really good rule of thumb is look at the inside of the person's cheek. It may sound gross, but really your mouth to your rectum is all connected. It's all GI tract. So it should all be relatively the same, right? Nice pink color, moist, healthy tissue is what you see kind of inside your mouth, right? So that's what your stoma should look like too. It should be moist, it should be pink, it should be blanchable. Things that you want to pay attention to are for signs of edema. Now, it's just been cut, so it's going to be a little swollen in the beginning, but that swelling should go down within 4 to 6 weeks, and they should have a pretty good idea what that stoma is going to look like at that point in time. All right, but if it's like inverted or prolapsed, where it's like literally fallen out and looks like almost a long snake coming out, those are all bad signs. If it's not blanching, or it's not, the color doesn't change when you push on it, or it's not soft, another thing is called budding, budding, and that's what it should look like. It should look like, I kind of think of it, it sounds weird, but a rolled sock that's like sewn to to your abdomen. So, as you fold over your sock, that's what's sewn around the edges. So if any of that's pulling away, those are all bad signs, okay? And you're going to want to let those surgeons or physicians know. Other things that we want to watch for is fecal output. It takes about 3 days to really start putting stool out. Prior to that, it may put out some serosang drainage and that kind of stuff just as it's healing from being cut and going through the trauma of surgery. But stool takes about 3 days. After about 3 days, if you're not seeing any stool starting to come out, then you're going to want to assess, has this patient eaten in the last 3 days, or are they still NPO? Because if they're still NPO, again, they don't have much in that system, not a lot's going to come out. You might have to give them another day or two. If they're starting to eat and take in well and it's not coming out, we need to figure out what's going on. Other things that you might want to know is it passing gas? Is there gas filling up the bag? Is there gas coming out? That all are signs that the stoma is working and actively going. All right, so here's different types of ostomies. Here you have the ascending colon, right? Ostomies are pretty much named for the area that they are in the body, right? The job of the colon is to literally squeeze the water out. That is the basic job of the colon, okay? So basically, any part from the ascending colon, if it's here, this is going to be really liquidy stool coming out. Then you've got your double barrel, which this is usually more a temporary type of ostomy and not so much a permanent one. I can't say I've ever even seen a double barrel in mine. But again, you're in that transverse spot. So it's going to be a little bit more firm than the ascending colostomy, but still pretty liquidy. As you get into like the descending, you're going to have much more firm, okay, because it's had this entire path to squeeze water out of it. So this is going to be much firmer stool. Once we get down to this sigmoid, this is going to be really firm stool, and this person may be able to not wear an appliance. They may just be wearing like a plug kind of thing over it, so that they because they know when they're going to have to go, or they'll get on a routine. Routine works really well for this the sigmoid colostomies, maybe even sometimes the descending. But again, these are all ones that have had a long time to squeeze and reabsorb all that water prior to it coming out. The ileostomy, however, look at that. That's in the small bowel. So what do you think about that? This is going to have a ton of water. So one of the biggest worries about an ileostomy patient is going to be their fluid and electrolyte balance, right? Because they have not used any of this area to squeeze any of the water back out into their body or reabsorbed that fluid back into their body. So dehydration is a big risk for ileostomy patients, and we really have to watch that closely. This slide really just reiterates most of what I've already talked about, okay, because we want to measure that intake and output. Again, those ileostomy patients are going to be really priority with this output piece, because if they're putting out a lot of fluid, they're not taking a lot of fluid in, then we're going to be at big risk for dehydration. Evacuation and irrigation, it's something you can do. It's where they put in like a cone and they can literally give themselves like a little enema. That's for people that have like a really scheduled, they know when they're going to go. It'll stimulate the bowel to move and go. So gets to be a very complicated procedure. And if you ever get the chance to watch an ostomy nurse come in and talk to someone, this is stuff they'll talk about, very, very specific to them. Cultural issues with ostomy patients. Again, we've talked about that. That this is a huge change in lifestyle. And, I mean, think about going to the pool. Think you can go to the pool with an ostomy? You sure can, but you have to just take different steps. But people are going to look at you differently if they see an ostomy pouch on your stomach. So that bikini that you used to wear, that might be a little different now. But nowadays, I see bikinis and ostomies all over the Facebook and stuff like that now. So, the culture is changing, which is good, right? Peristromal skin. So that's the skin that's right around the stoma, right? We want to look at that skin because it's going to have adhesive on it all the time. So we really want to pay attention to it. Things that might be red flags is if we have areas of redness. Okay, and then we're going to put adhesive on that. That sounds like bad news bears. So we're going to want to pay attention to what's going on in that area. The protective barrier stuff is really nice. No sting is one that I've used a lot. You put that down and you'll put it over this area, and then you'll put the adhesive wafer on, and that really helps keep the skin safe and protected. So those are things that we want to do. But again, you're going to do a lot. Ostomy nurses are pretty amazing. So make sure you really work with your ostomy nurse as providing good care for these patients, because they really, they have so many tricks up their sleeves. Just make sure to listen to them. Changing the collective device. So that's the bag that we've talked about, right? So here you're going to have the bag. You've got the adhesive on there with that. And then you're going to have your bag. And usually it's going to have some sort of emptying piece here so the poop can come out when you unclamp it. So you're going to want to make sure that that's clean, right? Because the worst thing is for one of these things to pop or blow. Make sure you're paying attention. And again, I think it's really important that we talk about these psychosocial concerns. Women can still get pregnant. Can still have sex. They can still, you can still do everything a normal human can be. You just go to the bathroom in a different spot. And one of the best things that I ever learned from an ostomy nurse is she said that, you're going to buy yourself a bag. And whether you're buying yourself a body bag or you're buying yourself an ostomy bag, you get an ostomy bag so you can live. So you can live a normal life. Either you've had irritable bowel, you've had Crohn's, or you've had some sort of cancer. This bag allows you to live. And I thought that was a pretty awesome way of putting it. Okay, so documentation. We aren't nurses if we don't document it, right? So here is an ostomy, and we're looking at it and just thinking about, so we've got our stomas red, which red is good. A lot of times we learn red is bad with so many things with, infection and incision sites, but with a stoma, with that ostomy, you really want them red, okay? Budding, here's that word, okay? Because you can see that it's like like it's butted up against this wall here. I guess red you can't see super great, but see how it's just kind of budding, and it looks like it's usually sticking up a little bit, and then it looks pretty moist. So those are all good things. Then we have skin around that is dry. Okay, we see all that skin, it's dry, other than it looks like maybe a little shiny to it. There's no open areas, and it's pink kind of under that wafer spot, so that maybe just signifies that something we want to keep an eye on, okay? Because if that stuff starts breaking down and we're still having to put adhesive on it, we want to be preventative as much as possible. So pink under wafer. So that might signify that we need to start putting prep on there to help protect that tissue. Patient denies itching or pain, stool present. Sometimes you can say how much stool, what color the stool is, how soft it is. You can see by where this is that this is going to be more formed stool because it's more on the side of the colon that is going to allow for firmer stool. So more in that sigmoid colon area. So the exemplars for this concept is an intestinal obstruction, and you will be doing a case study that should be right below this on your Moodle page for this actual exemplar.